I'm Dr. Brian Koffman. I'm a family doc, a doctor turned patient, and I'm here with my friend Dr. Bill Wierda at ASCO 2013.
Hi, I'm Bill Wierda, Professor of Medicine at the MD Anderson Cancer Center, Center Medical Director for Leukemia, and head of the CLL section.
So Bill, I wanted to ask you, we've had a number of prognostic factors, kind of old school ones, newer school ones, FISH, but there's some new stuff that's happening in terms of prognostic factors. So what does that mean to a group of patients, to an individual patient? Can you kind of fill us in on what's happening with prognostic factors in CLL?
Sure. So I've been working on prognostic factors for a number of years. We've been routinely measuring some of what have been considered the newer prognostic factors since 2004. That includes FISH for cytogenetic abnormalities, mutation status, ZAP70. And in our early work, we were developing prognostic models for significant endpoints: survival, time to first therapy. And what we've wanted to do is to incorporate the old traditional factors like rise stage and lymphocyte doubling time with some of these newer prognostic factors. In order to be able to reasonably do that with the data set that we have, we need a significant amount of follow-up. And right now we're just now getting into an era where we can assess the older factors, bring in the newer factors, and determine which ones are independently associated with important endpoints like survival. So I mentioned the ones that we've been routinely doing since 2004. Now there are a whole host of additional new ones that have been reported recently, and our job will be to assess those, put them in our data set with patient information, and to, in the future, analyze those and to determine which are the significant factors. The predominant group of factors right now that are the newer factors are genes that have been identified as being mutated in patients with CLL. Genes like Notch1, SF3B1, MYD88. So there are several of these genes that have been reported in the literature through exome sequencing as being...
So the exome is a large part of the genome that you're looking at, and you're sequencing that to find what actual genetic changes there are.
So there have been several groups that have done just what you're saying, taken the genes that are expressed in the disease and identified ones that are mutated. Now, the surprising feature to that data that's been reported is that the frequency of gene mutations is relatively low. So there aren't a lot of cases where patients have mutated genes. It's probably less than 20%. Who have in untreated patients who have a mutation. So they are relatively infrequent event. At MD Anderson, for our standard workup, we've been trying to work with our molecular diagnostics lab to develop a panel of these genes that have been reported to be the most frequently mutated genes and do sequencing on those specific genes. So we're in that effort right now. There's only a couple that we're doing routine sequencing on. For example, TP53 we're sequencing, ATM we're sequencing on a routine basis, and I'm working with the molecular diagnostics lab to bring in some of these other newer ones so that we can routinely do those sequencing for those genes and identify which ones are prognostically relevant.
So are some of these changes, if they're not in the genetic material, are some of these epigenetic changes that we're seeing in CLL and further down? Or?
Well, so in terms of the epigenetic, there's not as much as there is in other diseases in terms of importance of epigenetic changes and gene expression in CLL. So for example, there is methylation of ZAP70 that's been identified as a potential prognostic marker by the Ohio State group. But in terms of epigenetics and that correlating with treatment outcomes and prognosis, there's not a lot of data to support any of that at this point.
Talk to me a little about Notch1 and the risk of Richter's transformation and how important that is, or where you see that fitting in.
Notch1 is a gene that's been reported to be mutated. Mutation of Notch1 potentially activates that molecule and makes the cells more proliferative and resistant to cell death. It has been reported as a potential prognostic feature. The Germans reported at ASH this last December interesting data showing that those patients who had Notch mutations had similar outcomes on the randomized FC versus FCR trial, whether or not they got rituximab. So rituximab wasn't beneficial to patients who had Notch1 mutations in their report as an ASH abstract. So I think that's one observation, and there'll be many, many others that are reported as we do routine gene sequencing and do the correlations. Retrospective, obviously, because most of our early identification of important prognostic factors comes from retrospective data, where we go back and take samples from patients treated on a clinical trial and do sequencing or protein assessment.
So that's why I should be generous with my blood when I see you or Dr. Kipps and give the extra 6 tubes, because you're hanging on to that to look at that years down the line when there may be some prognostic factor you don't even think about right now that you want to test and see, did he have that 2 years ago? Did it make a difference in his outcome?
Absolutely. And to the second part of your question, which was related to the Richter's transformation, there haven't been really any features, as far as I know, that put patients at higher risk for Richter's transformation. We do know that patients with 17p deletion tend to have a higher incidence of Richter's transformation. Whether that's related to what happens to the CLL cells because they have loss of p53 and potentially mutation of p53 versus a risk that's rendered by their prior treatment exposure and that making them at increased risk for Richter's transformation. I don't know that there's a lot of data that gets at that at this point.
So let's take one step back and just kind of translate this for the patient. So we've talked some fairly technical stuff here. So what does this mean? I'm a patient, I'm showing up to you, you're going to run this panel of stuff, and I'm going to get back this sort of mix. It's never quite absolute, like you're at this end or that end. You're usually somewhere in the middle with some good prognostic factors, some bad. Help a patient understand what that means when their oncologist, hematologist hands them these results.
I think from a patient perspective, I think this is an extremely important discussion because I get the question and have the discussion all the time, and it's hard, I think, to have a lot of information, and a lot of times you want to act on that information, and you probably shouldn't. I think the most important thing about prognostic factors for patients and for clinicians is that there is very limited data that we can act on from a clinical perspective with regard to the prognostic factors. They're more informational. They more tell us how the disease may behave than how to manage the disease, except for when patients need to be treated. So in terms of patients who are newly diagnosed and are early in their clinical course, the prognostic factors may be helpful to determine how closely they need to be followed by their doctor, but certainly they shouldn't be acted on. If a patient has, for example, 17p deletion on FISH when they're newly diagnosed, that patient probably needs to be closer monitored than they would if they didn't have the 17p, but certainly they shouldn't be treated unless, of course, they're being evaluated and treated on a clinical trial, on an early intervention clinical trial, specifically for that subgroup of patients. People are nervous about it, but we know that at least for 17p deletion, there's a subgroup of patients who don't have aggressive disease and their disease doesn't progress. And so if we took everybody who was identified with 17p when they're newly diagnosed and acted on it and treated those patients, we would be doing a disservice to the group of patients who wouldn't otherwise have needed treatment. So FISH, I think, in terms of the prognostic factors and management, FISH is the most important because FISH will help direct treatment when patients need therapy. If a patient has 17p deletion and they need treatment, that patient goes into a high-risk category and they should be looking for clinical trial, and they should have transplant in the back of their mind. If they have an 11q deletion on FISH and they need treatment, they should be considering, or their physician should be considering, an alkylating agent containing regimen. So those are really the two examples in patients who need treatment where the prognostic factors make a difference. There is this early data about Notch1 and potentially FCR not being any better than FC, but that's an early report that's been reported in an abstract, and it's not data that I would act on clinically until it's vetted, we have more follow-up, and it appears in a peer-reviewed format in a publication.
So you mentioned clinical trials, and I know that there was a trial years ago with famously compared chlorambucil to watch and wait, and found that actually chlorambucil maybe had a negative effect on terms of outcome. And that, I think, kind of scalded people's fingers in terms of trying the early intervention. But now we have much more efficacious and in emerging less toxic therapies. Do you think that there may be clinical trials that will look at these high-risk patients that you're advising right now, watch and wait, or consider clinical trial? Are those in the works, those trials?
Sure. So there's a German CLL study group trial that has identified a high-risk group of patients who don't need treatment otherwise, but they're still high risk. They may have 11q or 17p or an unmutated V gene. And on that trial, patients are randomized to observation or early treatment with FCR. And so that trial's been ongoing for several years, and I expect over the next 2-3 years we will have some data from that study. Certainly with the non-chemotherapy options, we're also excited about doing those early intervention type trials, particularly for high-risk patients. So the answer to your question is yes, there's an ongoing trial with early intervention with chemoimmunotherapy, and I think we will be seeing trials with the newer agents for high-risk groups to see if that also changes the natural history of the disease.